this is our thing right here?
Yep.
Okay. So my talk, I didn't want to overlap too much with Jim. We are not often at the same conferences because we're both surgeons, so I didn't want to overlap too much because I've heard Jim's talk before. So I was going to go in to sort of how we make decisions, surgical decisions, maybe non-surgical decisions, but what are some of the key variables that I think are important for you to understand in your position when you're going to appointments and trying to ask questions from the neuroendocrine person that you're seeing on how the medical decision making is important to you. And why that is relevant is because, as Marianne said, even though diagnoses may be seemingly similar, patients in neuroendocrine can often be treated differently because of the very unique features of their case. So I think it's really important that people understand the unique features of their case that drive the medical and surgical decisions. So my objective is to better understand the variables that weigh most heavily into medical and surgical decisions, the data that best supports surgery, explain how surgery is only one of many treatment options and none of them are mutually exclusive. What is morbidity? That's really just the complications associated with both surgical and non-surgical treatments. What is it and why does it matter? And then they did ask me to talk about histotripsy in the context of neuroendocrine tumors, primarily because there's a lot of chatter on the internet that is lacking some clarity when it comes to neuroendocrine. So we've probably treated the most patients with neuroendocrine tumors with histotripsy, so I can put that in perspective for you. So what's super duper important, and this is where all of us have a little bit of our hokiness. So they're not mutually exclusive, and then if you've ever watched any of my videos, I have a very particular way of describing some of the different treatment options that we have. But there are a number of treatment options, many of which you are going to hear about today. I think the one thing we may be lacking is a bit of the chemotherapy, but many of us are going to be familiar with the chemotherapy. So if you have chemotherapy questions, we can answer those even if there's not a specific talk for it. So there's the chemotherapy that's going to be standard of care for the higher grade tumors that Thor talked about, liver-directed therapies of which they're both catheter-based and ablation. There's the PRRT that just you heard about, and then there's going to be surgery. So this is my car and parking space analogy. So Thor sort of started you on with much prettier images than mine, but the prettier images, which is these well-differentiated tumors or lower-grade tumors, will have a well-preserved somatostatin receptor on the surface of their cells. And if that is the case, then a lot of the therapies that we use for those tumors are going to exploit that somatostatin receptor. So if you really think about there just being these cells, and that the cell has this parking space, and a lot of what we're doing is just sending in some treatment, and that treatment is ultimately searching for that parking space, then a lot what we're doing is trying to either, radiate, surgerize, or somehow obliterate parking spaces so that you have overall less tumor burden, and then you are more likely to then be able to control the disease over a long period of time. So when I'm talking about somatostatin receptor analogs, that's just like injecting you with a bunch of little cars that are driving over your whole body looking for a parking space, and like a police officer putting a boot on the car is trying to cripple that cell. It is very good at controlling the chemical production from that cell that gives people carcinoid syndrome, but it also messes with the mechanism by which that cell divides. So that's why somatostatin receptor analogs are a standard of care method for patients with somatostatin receptor avid tumors on PET imaging. And that can be what people it may be the only thing people need for their entire disease course. So that when you think about it in the context of the extent of disease that one patient may have that another patient may have, sometimes we will be having a conversation about whether or not there are realistic expectations on whether or not a single dose of a drug is going to be able to manage this extent of disease. And if there's any question in my mind that that drug alone will not be able to manage that extent of disease, then we will talk about using complementary techniques, meaning you will use strategies that will combine two of the treatments that I had just listed in hopes of making it a fairer fight, that someone would then be able to diminish or reduce the total disease burden, whereby somatostatin receptor analogs would be able to manage the remainder of the disease. PRT, which Thor just did a great job, is really just injecting you with the same little car. It drives over your whole body. It's got a radiation particle on top of it, and it binds to that same parking space, and the cell is just dumb enough, like a whale, to swallow the radiation particle. It damages the DNA of the cell from the inside, and it is a very effective, targeted radiation therapy relevant to patients that have somatostatin receptor avid tumors on PET imaging. I completely agree with Thor that I wish we'd get away from talking about it being the isotope as opposed to the scan. I also use the term somatostatin receptor PET as opposed to any particular PET because it really, people feel like they get a substandard quality if they get the wrong PET. No, they're both the same PET and they are both excellent. So the somatostatin receptor PET is super important because the somatostatin receptor PET is like injecting you with a bunch of little cars. You're going to get tired of the car analogy. A bunch of little cars. It's got a pizza delivery light on top of it. It is searching your whole body for the same parking spaces, and it's sending off a signal. That SUV, that number on your imaging, the higher number just means that you've got more parking spaces on that cell. But why that's so important is that the car that we use for many of the PRRTs is the same exact car that we use for the PET scan. So if you get a PET scan and it tells you, oh, that's where all the activity is, well then when you inject the person with PRRT through the vein, you have a sense of where that PRRT is going to go. And if you've got activity in your eyeball, well then you can't control where PRRT goes, so that depending on the activity in your eyeball, we may be more or less sensitive to whether or not we want PRRT to go there. And then surgical section, I put surgery, resection, and catheter-based liver-directed therapies because those don't matter whether or not something is somatostatin receptor avid. Surgical resection is like taking a weed out of your lawn. You go and you see the weed in your lawn, and you take your shovel and you dig the weed out of the lawn. And yes, you will have several little divots in your lawn. I have a picture of that. We call it melon scooping. So what's super duper though important, if someone is using the word surgery in the context of neuroendocrine, we do a very different type of liver surgery for neuroendocrine than we do in other metastatic cancers like metastatic colorectal. You have to try to preserve as much liver function as possible in neuroendocrine, and the tumors tend to be pushing tumors, not invading tumors, so you end up almost like teasing them away between the interface of the tumor and the liver, instead of taking large amounts of normal liver function along with the tumor, which we need to do in metastatic colorectal for a variety of reasons. So it's sort of important if someone's talking about surgery, whether or not they're comfortable with the types of surgery we do in neuroendocrine, because it is somewhat different. We scoop them out as opposed to chiseling them out of a larger piece of liver. And then catheter-based techniques. This is when I say that's done by an interventional radiologist. It has been used to treat this disease for probably 50 plus years. The techniques have gotten a lot better. They come in different platforms, but it's also sort of important to understand what different platforms there are, because when you talk about people that live in the world of neuroendocrine, whereas neuroendocrine is some component of a more broad medical oncology practice, we in general don't use radiation particles for liver-directed therapy. That's called yttrium-90. We tend to not do that in neuroendocrine because then we worry that the tolerance of PRRT, if we were to have to pull that trigger in the latter stages of treatment, that then the double dosing of radiation into the liver would be, unwise. So catheter-based techniques are like going to the state fair and you have the arcade and you got your little air rifle and the targets come up and you're trying to hit the targets for points. And an interventional radiologist can exploit the anatomy of the liver, which is really just like a tree. It's got a trunk, it's got two main branches, and then as those branches enter this very complicated three-dimensional organ, an interventional radiologist can maneuver a catheter into the different branches of the liver and go almost straight up to the target, where you are only treating, you can treat a single tumor. These are these little things right here, if I've got this little thing. So this is like this, so that's a tumor that he's seeing on his scan. So he can go up and go into this tiny little branch. We call that super selective embolization. So if you were doing your research and you say, oh, super selective embolization, that means they're going as close to that target as possible, because then you can annihilate a single tumor without getting any of that therapy into the normal background liver. So technique's been used for, probably decades. Surgery's been used for, centuries. We've just gotten a little bit better at it. Obviously, somatostatin receptor analogs, another decades. PRRT, probably maybe 15 years. So other things that I think people need to understand are some of the definitions that we don't always use, but definitely we use when we are talking to each other within the medical community, is the difference or the goals of treatment that are pertaining to whatever case we are talking about. So when we say that we're doing something with curative intent, that means that the procedure that we are doing is meant to eliminate this as a problem for you for the rest of your life. Now, obviously in cancer, we will do something with curative intent. That doesn't mean that the cancer doesn't recur. But ultimately, there would be data to suggest that a certain proportion of patients, if you do this therapy, will never have this problem again for the rest of their life. So if you talk about cancer in general, breast cancer, colon cancer, lung cancer, whatever, if something is done with curative intent, it is trying to eliminate it as a variable. So in neuroendocrine, it is to diminish the extent that we would have a neuroendocrine specific event. I think Thor went into that as part of his PRRT talk. If something is done with palliative intent, it is meant to alleviate symptoms that are related to the condition, diminish side effects related to anticipated progression of disease or tumor growth, where the success of the treatment is not measured in quantity, but in quality of life. That does not mean that when something is done with palliative intent, it does not prolong your life. It just means that the goals of treatment are different. With people with severe carcinoid syndrome, we can aggressively treat them with active therapy. And if we meet the goal that their carcinoid syndrome gets gobs better, then we have met that goal with palliative intent. And then in neuroendocrine, we do believe that if we meet the palliative intent goal, then people will likely live longer because their life is in general better. And then prolongation of life is what most of everything that we do in cancer is about. It is saying that what we are going to do, this treatment, this drug, this treatment strategy, when successful, it's associated with a longer expectation of survival compared to no procedure or medical therapy alone. So although that wasn't exactly how Thor had presented it, that's what he was presenting with all of those different when he's saying that retrospective data is saying, I'm going to look over a bunch of patients that have been treated with these different things and say, hey, can I glean from that a prolongation in life had we taken this strategy, whereby we would be more likely than not going forward take that strategy over whatever the other strategy options are. So even though I don't expect a patient to walk in and say, doctor, is this being done with curative intent or palliative intent? In neuroendocrine, a lot of what we deal with is going to be in this category whenever we're talking about metastatic neuroendocrine, is that we are dealing with prolongation of life, which, as Thor said, we have made a lot of progress, and neuroendocrine patients are living longer and longer, and many patients will live to actually succumb to something else. But that it's not to say that we don't do something. I've got some examples of curative intent. So surgery done with curative intent would include a midgut primary. I call it midgut because, like Thor, I'm semantics. That means it's in the small bowel. So a midgut primary, that means you're doing a small bowel resection with a mesenteric lymph node basin, and you're getting rid of all measurable disease. So that's a great category to be in. That's when we were talking about early stage, regional involvement, no metastatic disease. If you were to look at the odds of someone with a node-positive midgut primary over an entire lifetime of 10, 15, 20 years of developing or having a neuroendocrine-specific event, it is rather high. But that it doesn't mean that a good chunk of those people, 40, 50, 60% of those people, will live to not have a neuroendocrine-specific event that is done with curative intent. A pancreas primary, where the pancreas resection, the peripancreatic lymph node dissection is done. A lung primary, where we resect the lobe, plus or minus the lymph node dissection, depending on what the extent of disease is on preoperative imaging. So those are all saying I'm eliminating all measurable disease. And then there is going to be a category that is going to be where you have very limited metastatic disease that can be completely removed. And although we have tempered expectations on those patients not having a neuroendocrine specific event, if you're doing those operations in someone with other medical conditions that are drivers of mortality, you can still probably eliminate the neuroendocrine component as long as you are removing all measurable disease with that operation. So surgery done with palliative intent, we call that surgical cytoreduction. I think that Dr. Howe will probably go into that in more detail. That is removing enough tumor burden to decrease the symptoms associated with the disease, or removing enough tumor whereby somatostatin receptor analogs are better able to keep the remaining disease in check. And then that is when tumors are causing obstruction, bleeding, perforation, and all the things where we are palliating the complications of the disease growing in that site. And then surgery done with prolongation of life is that if we can treat someone with surgery and remove some critical mass, of which a number of papers have tried to define exactly how much that is. I think Jim Howe and I would agree that there's no magic to 70 versus 69 versus 71, but that when you're looking at some of the complication rates of these surgeries, I don't think we need to push it to 90. But that we also can't jump in and take people to the operating room if there's no chance that we're going to meet the 70% surgical cytoreduction, because that's exposing them to complications for no established benefit. So we say that greater than 70% of the metastatic tumor burden can be removed with that surgery, and then we need to know kind of where it is and what would it entail to get that done. And then morbidity is the complications associated with the procedure. I have a little bit more about morbidity in a later slide. So the three main questions that you are asking yourself and the surgeon that you're talking to is, can all measurable disease be removed? That would be done with curative intent. What are the risks associated with the operation? And do you have any other medical problems that would influence your ability to recover from the operation that is proposed? So this is just some small bowel and colon anatomy. I think that Jim Howe will probably go into this in more detail. And so when you are talking about or looking at your imaging, and the radiologist is mentioning all of these different parts of your body, is that for the most part, the midgut is something that is relatively complicated and more difficult to understand. So the guts are really just a sausage right here. Okay, this is your small bowel, and you see all these red things are just the arteries. The arteries are coming in, so they start off in this highway up here. So this is the highway of arteries, and this is all going to be the things that are going out towards this sausage. So the blood flow is going this way. The lymph nodes, are all the trash that's being produced by your intestines, are going this way. And so within this mesentery right here, which is this fatty little thing right here, you're going to have both the arteries and the veins and the lymph nodes. And so with small bowel primaries, you're going to have a primary right here, and it just like a breast cancer goes to the lymph nodes underneath your arm, these go to the lymph nodes within the mesenteric basin, and I have some pictures in the next slide. So this is not really what it looks like. It really looks like this. So the colon, very similarly, it's got its own little blood supply. So if you were to lift this up, no, you don't really look like this, but if we were to skeletonize all of those images of those fatty tissue with all the lymph nodes, this is ultimately what it would look like. So then this is how we evaluate it from a surgical perspective, is that something that is here. So here is the small intestine. This black dot is going to be a lymph node that is sitting into the mesentery. Right here, that would be equivalent to this. An operation to deal with something here versus this thing that's got a big tiger on it, we call this tiger country, because this is, you've got a lymph node involvement that is at the base of the mesentery, and it is involving, it's like having a rock in a stream that involves all the outlets to the entire small intestine. So when a surgeon is saying that something is not a good surgical candidate, or is too risky, or you're going to lose too much bowel, what they're talking about is how much bowel are you going to lose in order to not only get rid of the primary that is way out here in the sausagey part of the thing, but what is it going to take to relieve then the lymph node involvement that is going to be within this part of the mesentery. And so this isn't just an example of this is what that is. And so this is it. So this is not tiger country. Tiger country is right here. But this is a large mesenteric mass within the small bowel mesentery. Here's the primary. right here. So you can have a small primary, you can have a big problem in the mesentery, but it's the mesentery that ultimately has people develop complications associated with midgut primaries. The pancreas anatomy. The pancreas is like a fish. It's got a head, a neck, a body, and a tail. And the location of a pancreatic neuroendocrine tumor totally matters because the complications or morbidity associated with operating on the pancreas is very different if you're trying to get something out of the head versus the tail of the pancreas. So the head here is all intertwined. It's like Grand Central Station here. This is going to be the first portion of your intestines right as it's coming out of your stomach, called the duodenum. Yes, and all of this has a common arterial and blood supply and lymph nodes that are related to the head of the pancreas. And so taking out the head means you got to take out the head, a sort of a portion of the duodenum, a portion of the bile duct, sometimes the portion of the stomach, and then you've got to hook all those things back in. We call that a Whipple procedure. So that's a big deal. And so if you've got, as Thor was saying, is that if you've got a small or slow-growing or well-differentiated tumor within the head of the pancreas, and one person is saying, oh, hey, I think you need an operation, and then your other second opinion says, over my dead body, are you doing an operation? Because the operation comes with risk. So we do, although I absolutely agree that we don't always have clear-cut sort of rules of engagement that we all use. I think we've all come to appreciate the complications related to some of the surgeries that we do. And so we are very careful to suggest a surgery on something that is not a life-limiting problem for a person. But if it is a higher grade tumor, more aggressive, lymph node metastases, and it's the only site of disease, oh sure, we will do that operation with curative intent. The neck is even worse. If it's in the neck of the pancreas, it's sitting over all of the important vessels that are going to the small intestine. So when tumors are in the neck of the pancreas, is probably the most challenging for us because we either have to extend the operation that I just talked about, making it even bigger, or we have to take out almost 2/3 of an entire pancreas, increasing significantly the risk of someone becoming diabetic. And then as you move out through the body and the tail, those are most commonly done, minimally invasive, done under robotic, and it's really like going to the fishmonger and saying, I just want the tail, and they go, choop, and then you just get the tail. So bronchopulmonary neuroendocrines, bronchopulmonary is also like a tree. So you've got typical, atypical, you've got multifocal, and then you have a disease that we think is likely just a paraneoplastic syndrome called Dibneck. Tumor location also determines the operation, and very similar to the pancreas, we do not go all in aggressive on bronchopulmonary neuroendocrines unless we are doing it with curative intent. So, for example, something way out here, you may just lose a lobe of your lung. If it's right here, you may lose half the lung, but if it's right in the center, you may use the whole right lung. And there will be reasons why we would do that operation, but that if someone was saying, oh, this is the operation that I would recommend under those circumstances, that is when I would get a second opinion, because I think that we may have slight differences of opinion on how aggressive we would be based on any individual pathology. Multifocal bronchopulmonary neuroendocrine tumors are usually typical. That means that they are very low-grade, well-differentiated, and likely overlapping with other pulmonary hypersensitivities that people have. We are less likely to take an aggressive surgical approach, and we often actually use watchful waiting instead of putting people on systemic therapy, but that there is certainly some data to suggest that we can use systemic treatment with the SSRIs. And then the liver surgery anatomy, these are just my pictures of the melon scooping, is also like a tree. So you've got the trunk of the tree, the two branches. These are all of the individual branches. And so a tumor way out here is actually, this is the image of that, is actually pretty easy to tease out of there without actually jeopardizing the integrity of any of these more central structures. One that is much more central within it, we may decide that liver-directed therapies are the more appropriate, less complicated method or treatment strategy to treat something in that location. And sometimes just based on the anatomy and the use of an ultrasound, we are able to manage those operatively as well. And this is just what that looks like, is that you really just end up choosing it out, and those are just those little structures at the bottom that you keep intact. So surgery and survival. The strongest evidence is going to be in G1 and G2 midgut cases. If you were to look at the very large series, of which I think the largest are going to be from New Orleans and Iowa, all of us pretty much have very similar outcomes. If you can meet some critical mass, of which we've decided it's at least 70%, and that you can deal with all of the potential complications associated with the abdominal metastatic sites, there is a survival advantage. There's less robust evidence in metastatic pancreatic neuroendocrine tumor. Our most recent data would suggest that how you manage the metastatic disease is probably more important than how you manage the primary site, and that has a lot to do with the complications associated with a pancreatic resection. Much weaker evidence in metastatic longer bronchopulmonary net, and as we have clinical trials and some of the PRRTs coming out in bronchopulmonary, I think that we will be doing less surgery on metastatic bronchopulmonary, but if any of you are in that situation, we have certainly done it and have good data to support it in the cases that we've done. And there's very weak evidence in high-grade tumors. We would rarely do something in a high-grade tumor unless it is with palliative intent, meaning that that high-grade tumor has caused a life-limiting complication like a bleeding or a perforation. And then lastly, histotripsy. Histotripsy is an ultrasound-based treatment, and I think people understand the word tripsy because they understand lithotripsy. So lithotripsy is a low-frequency pulsed ultrasound like a jackhammer. That's actually like what a lithotripsy machine sounds like. It's like, and that is because you need a jackhammer to break up a calcified kidney stone. And then there's something called HIFU, which is high intensity frequency ultrasound, and that is, because I don't have a better analogy, like trying to start a fire in the woods with a magnifying glass and the sun. Is you're trying to use very high frequency, constant ultrasound to generate heat, and you're just going to kill that tissue by heat. And then over the last probably around 15 years, they have found that you can alter the way that you are pulsing the ultrasound in order to get out of the heat business and out of the jackhammer business, and you are able to destroy tumor using something called cavitation. And cavitation is almost like you are reverberating against the cell to the point where you are disrupting the membrane, and so you still have the innards of the membrane, but they are no longer able to function. And although it's only in animal-based studies, and then we have some select examples of when we believe that there has been some sort of a systemic or an all-over body response to that, that's this whole immune response people are talking about. It's also called something called an abscopal response, is that if your body is all of a sudden seeing the innards of this cell, they're saying, hey, what's going on over there? And they are sending an immune response to that area. And in doing that, you can also get an effect of histotripsy on tumors that are not actually the ones that were targeted with the treatment. So it is kind of a neat, exciting thing. I just don't want to I don't want people to get all so hung up on that they would choose something like histotripsy, which is just getting through the FDA, over some of our more tried and true techniques that we have all really come to support with evidence, just because it happens to be a non-invasive technique and it's got this, amazing immune response. I think that most of us that have done neuroendocrine patients have not been that enthusiastic about some of the immune response. I do have an example of one where I feel like maybe she had it. So the sense of a difference in tissue collagen content, that's probably the most important, is that if you have a system whereby it's treating this tumor and it can tell you the difference between the content of this microphone and this desk, and so that treatment is going to go right up to the periphery of that, and then it's going to sense that difference and then stop. It's almost like it's a self-controlled situation. That is really great when you're treating in really tight areas, so that if you are sitting up near a bile duct or a blood vessel or things like that, where some of the other techniques like radiation and thermal ablation will injure those adjacent structures, you don't have that same problem with histotripsy, and I can definitely attest to that. We have treated neuroendocrine tumors in very, very awkward locations and not had problems. With significant complications, so there's less potential to damage normal tissue. So for metastatic neuroendocrine tumors, obviously it's only FDA approved in the liver. It's really just coming in as something that is least invasive because it doesn't involve poking or prodding, but it is done under general anesthesia. It is potentially less expensive, certainly if you were comparing it to some of the more expensive catheter-based techniques or SBRT, and I do believe that the clinical trials are going to be coming out trying to use it in combination with systemic therapies. So I just have some examples so that you can understand what our experience has been. This is just probably maybe similar to one or more of your cases. A young person, long-standing history of metastatic neuroendocrine, grade 2, horrible carcinoid syndrome, having to have rescue shots almost daily. And he was really reluctant to take on PRRT with relatively small volume disease. So he had this tumor sitting right in the center of his liver. This is just a different image from his SSR PET. This is just how hot it was on that. The SUV was around 28. Not the highest, to be honest with you, but that compared to his other SUV values, I figured, gosh, if I can just take out the hottest one, maybe I would better control his symptoms. And it was really, I mean, he has no other medical conditions. He desperately wanted this done, and he didn't want liver-directed therapies. So his follow-up was, I will tell you, now it could have been placebo because he really, really wanted this technique, but that his symptoms improved right off the bat. But more importantly is that he was our first case, so I was very conservative in what I did. I am so much more aggressive with the types of voltages on histotripsy I use now than I did in this guy. And so I even told him, I said, hey, let's just see how you do, because it's not like I can't hit it again. It was a very easy technique. He looked great afterwards. But I went kind of for the lowest thing because I didn't want to hurt you. And despite that, his serotonin did decrease by 50%, and he came off of all of his rescue doses. And those are the types of things that you just can't fake. So someone can't all of a sudden have a placebo effect and say, I no longer need my rescue doses of octreotide. So I was actually pretty impressed by that, given the fact that I felt I was pretty wimpy with the technique, giving it my first, it was my first thing. So he did have stable disease and symptoms at 9 months, and then he started to have recurrent symptoms, although has not gone back to needing daily doses, but his serotonin level is clicking back up again. And whether or not it's because he has reemergence of the disease in the original area, or he's just got hotter activity in one that was just less avid when we hit it, is that I just wanted to say that it wouldn't have necessarily been my choice had he not wanted that thing. And then I did ultimately get enough data to say, hey, I think this has at least maybe some role in this disease. This lady is the one where I think that we probably did make an impact more so than I expected. She's a 77-year-old. She's got a number of comorbid conditions that would drive her mortality. Horrible carcinoid syndrome, serotonin levels in the 1400, carcinoid heart disease, and she has been on almost every treatment to date, including CTACE, PRRT, chemotherapy, and surgical cytoreduction. So she was having worsening carcinoid syndrome. I took a very similar strategy to what I did with the first patient, although she was my probably 16th patient, and I felt a lot more comfortable with the technique by that time. So this was the disease that was the hottest. This is how hot it is on the PET scan. This is the post-histotripsy image. And she really did get a significant reduction in her serotonin. She was having these near syncopal episodes with her carcinoid syndrome. And she has probably had the most durable response. She is around a year out now, has had a stable serotonin level, stable disease on MRI. And why I think that I could convince myself that she got an all-over-body response where I have not even convinced myself at all that anyone else has, is that this was someone that was heading down the wrong road. She was heading down the road of progression of disease, and despite everything that we were doing, she was still having progression of disease and running out of options, and had a lot of comorbid conditions that were going to leave us tight. And yet she's had stable disease and actually is almost living her best life. And whether or not that's placebo or whether or not that's because she's having some effect, it's a little hard for me to tell. And then this is just one of those things on why I am not as enthusiastic about an all-comers. I want to make sure I'm being honest, seeing that the president of our society is sitting at the table, is that this is a woman that has had another long-standing history of the disease. We call it grade migration, when people have one tumor that tends to be misbehaving compared to the rest of the population, and we're like, what the hell's happening over there? It's like having one of your kids misbehave in a restaurant. You're like, what's going on, man? We call that grade migration, where if we were to biopsy that tumor, it may have a higher Ki-67 than the other tumors. So this is this person's PET scan. Is that this is the tumor? It's not PET avid. This is the PET avidity of the adjacent tumor. I hit that tumor, and you're gonna. I mean, I don't think you need to have a radiology degree to say that I don't see any difference between those two. Instead, you can convince yourself that maybe I don't know, maybe it looks a little different. But so I told her that I felt 100% comfortable that we had treated her in exactly the same way we had, and she was probably our 30th patient, and yet I did not see the result that we had. It has been stable probably now 6 or 7 months later, but I am not as enthusiastic about it in higher grade tumors. And then to lastly, the base of the mesentery is where I think that we have a lot of potential with histotripsy in the future. And that has to do with the fact that those are the cases that are very, very complicated because it's that tiger country. And so this is what they look like on a CT scan, and I can almost guarantee you, if you go to a number of cancer centers, and I completely agree with Thor that it's not necessarily that you need a neuroendocrine specific cancer center, but that this, I can almost guarantee you 90% of the time someone's going to say that that is a surgical insalvageable problem, yet we get probably around 75 cases a year referred to us for this exact problem, for which I think that 80% of the time we are able to help those people. But that if you can think about histotripsy in the context of being able to treat something that is so close to all of these tumors, I mean all those blood vessels, and have it even remotely respect the interface between that tumor and the blood vessel, my understanding and my own experience with histotripsy is this may be a game changer for patients that have very, very little options. I think that although I will never be able to prove it, but I have definitely operated on people that have had PRRT with tumors in very awkward areas, is that sending PRRT into there, like if this has high SUV, will cause a lot of radiation change that then ultimately I think makes those operations even more difficult and more complicated. So, and then how you would access the base of the mesentery, my feeling is that we're going to be able to do that minimally invasively by going in and just moving certain things out of the way. And then this is an ultrasound technique. It just needs water as a medium, and you'd be able to then fill up the abdomen with water and use the medium very similar to what we do on the surface of the patient with the current techniques that we use. And then I also think that it will be amenable to the pancreas. The pancreas data coming out in histotripsy from Spain is that it is going to be considered safe without significant complications like pancreatitis associated with those treatments. They've done probably around 15 patients now without having a significant complication rate, but similarly, I think we'd be able to target some of those neck tumors, the awkward head tumors, where the complication rates associated with the surgeries would be high. And I'm more than happy to talk about histotripsy in the context of individual cases, because it is, right now, I don't think that we really have an understanding of where it fits in the paradigm of neuroendocrine. So conclusions, I think it's a good option for palliation in patients with carcinoid syndrome. It certainly has helped over 50% of the people that we've treated for that indication. I'm cautiously optimistic in payers of grade migration. Our short-term data in patients with higher grade tumors is not great. I think we will continue to take patients with secondary tumors because I also run a rare cancer program, and I see potential for it in the treatment paradigm for base of the mesentery. And this is just the same advice you're going to get all day from trying to, if you need a second opinion, that's a good thing. If you hear even the same words out of two different people's mouths, it makes you feel a lot better that you're heading on the right treatment path. Sorry, I went over. No, but you know what, your parents